Hi, thank you for having me today. I'm Stephanie Austin. I'm a certified genetic counselor and a research program manager at Duke University. And today I'm going to give you a background on Pompe disease. I'll go through some background, the epidemiology, newborn screening, biochemical and the molecular genetic testing, genetics inheritance pattern, some common variants and phenotypic correlation, and then a few thoughts about genetic counseling for families. Pompe disease really is a continuum. It starts off on the more severe end with infantile Pompe, with symptom onset less than 12 months of life with cardiac involvement, and then over to the other end of the spectrum, which would be late onset, also encompasses juvenile onset and adult onset Pompe disease, which is really considered symptom onset after 12 months of life without significant severe cardiac involvement. The phenotypic variability really has led to the creation of the types based on age of onset and degree of organ involvement. And these subtypes have been referred to inconsistently in the literature. But various terminologies might include infantile onset, late infantile, childhood onset, juvenile, or late onset. But it's important just to realize that it's a continuum of disease. One important piece to consider as we're talking about Pompe disease, especially infantile onset, is the characterization of CRIM status, or cross-reactive immunological material. There's two types, CRIM positive and CRIM negative, and CRIM positive patients have gene variants that allow for production of some enzyme with or without the enzyme activity. And when the immune system is exposed to the enzyme, it may tolerize and then recognize the enzyme as self. Usually these patients who are CRIM positive have low antibody titers, and most have good clinical response, but there is an occasional poor clinical response, patients that have high titers to ERT. On the other side of the spectrum, the more severe case is the CRIM negative patient with two deleterious gene variants who have no native enzyme. Sometimes this is called a knockout, where there's no protein or enzyme made. And ERT is recognized here as foreign by the immune system, and usually these patients have high persistent antibody titers and a poor clinical response to enzyme replacement therapy. There is a significant amount of variability in late onset Pompe disease. The age of onset can range anywhere from the first year of life up to the 6th decade. And before newborn screening, there could be a diagnostic delay of more than 20 years. The differential involvement of the musculoskeletal and respiratory system, but there's typically no cardiomyopathy, although there can be some cardiac involvement, including rhythm disturbances. And when we think about the most common variants associated with late onset, we talk about this IVS. This is a splice site variant. And it's responsible for, it's one of the variants in about 60 to 90% of Caucasians with late onset Pompe. Each patient who has Pompe would have two variants that cause the disease, and 60 to 90% of adults with Pompe, with late onset Pompe, have this variant. It's considered to be a milder course of disease, although we are still recognizing what the clinical course looks like, especially in the newborn screening patients. And we have seen on a number of recent genetic tests, both prenatal and the newborn screening, that there can be some patients who carry two copies of this IVS splice site, and that we would refer to that as homozygous. And there can be some symptoms associated with that phenotype also. So I'll touch a little bit about newborn screening, because this is really important for a lot of the families who are newer to Pompe disease. And one of the questions is, can newborn screening change the course of the disease with early detection and treatment? And this is especially true for infantile cases, and I think it's universally appreciated for infantile Pompe cases. In children who are CRIM negative, these are the most severe cases, and these children can be treated as soon as they're diagnosed with Pompe by using immune tolerance induction along with ERT. And then in CRIM positive, we also see an important outcome with early treatment. But then there's also the question of how does newborn screening benefit patients with late onset Pompe? And we really are starting to learn more about what does a child with late onset Pompe look like? Because up until this point, many of the adults or people with late onset Pompe weren't diagnosed until the earliest would be a couple years old, and then into their 20s, 30s, 40s years old. I'm not going to go specifically into the guidelines, but there are a number of guidelines that have been published for general guidance for Pompe disease, both on the diagnosis and treatment side by the ACMG, and then also via the newborn screening working group for newborn screening, diagnosis and treatment. And those are listed here if anyone wants to take a look at those on their own. But when we look at the United States, state by state, we can see here the current adoption. And this is starting kind of in March 2013, when Pompe disease was first added to the recommended universal screening panel. And then March 2015, when the final confirmation was received by the US Secretary of Health and Human Services. And then currently 23 states, including DC, have adopted universal screening. And I did see today that Kansas actually recently added newborn screening for Pompe to their screening panel. So as we start to look at the pilot programs where newborn screening started for Pompe, first we know that Taiwan was one of the first groups that did newborn screening for Pompe. And then there were several other pilot programs in Italy, Australia, Japan, Korea, the United States. And by doing that, there were a couple outcomes. One is they demonstrated the feasibility of being able to screen for Pompe disease via newborn screening, but also the findings have impacted the incidence of the disease and helped us better understand what the incidence of the disease is. You can see here in the Missouri newborn screening program that about 1 in 10,000 children was diagnosed with Pompe disease. In New York, it was about 1 in 17,000, and then in Illinois, it was 1 in about 25,000. When we talk about what the incidence is of Pompe disease, we talk about 1 in 20,000 is what we report, but here you can see that these numbers can range. As I mentioned, the prevalence can be anywhere from 1 in 20 to 1 in 40,000, and this is what was originally described many years ago and was kind of held on to until we started seeing some of the numbers from the newborn screening programs. Incidence data really is limited with reports from 1 in 14,000 to 1 in 300,000, depending on the ethnicity. The infantile form of Pompe disease does have higher incidence in some backgrounds, including African American and Chinese, whereas the late onset form can have higher incidence in people in the Netherlands. And as I mentioned, the previous overall incidence of Pompe was about 1 in 20 to 1 in 40,000. And now what we're seeing is that this number could be as low as 1 in 8, 1 in 10,000, depending on the population screened. This was a nice paper that was recently published by the group in Pennsylvania when they looked at their population of patients screened for Pompe disease. And you can see that they had values ranging from about 1 in 8,600 to 1 in 23,000. And this data really kind of shines a light again on how common the diagnosis of infantile and late onset together can be about 1 in 8,500 when you add both types and you cover the entire spectrum of disease. So one key point here is that the prevalence of Pompe disease is far higher than previously thought. Therefore, the carrier frequency would be higher than we thought. So when we take the number 1 in 40,000, we would estimate from the Hardy-Weinberg theory that 1 in 100 would be carriers. But if we go to the number that we've seen in some of the newborn screening programs of 1 in 5,500, we would see that the number is much lower in that 1 in 37 people could be carriers. So if the prevalence of Pompe disease is higher than previously thought, and the carrier rate is higher than previously thought, it's possible that there can be greater than 2 variants or molecular changes within the family. And I'll talk a little bit about why that's important when we move to the genetic section. So let's switch over now to diagnosis and confirmation of diagnosis with biochemical and molecular genetic testing. There's a few different ways that we confirm a diagnosis of Pompe disease. One is enzymology on blood or skin, molecular, which is genetic testing, and this is also gives us information about CRIM status. Muscle pathology is often a factor or looked at, especially in later onset adult cases. And then labs and biomarkers also give us some information about a diagnosis of Pompe disease. Now, as I mentioned, this is a chart from the 2006 guidelines for newborn screening, and this applies to clinically diagnosed children and adults. But as I mentioned, there are a number of new algorithms where newborn screening has changed how this happens. There is a reference here, and you can pull that or let me know if you have any questions about it. So in an initial diagnosis, enzymology, or measuring the enzyme in different parts or different tissues, really is helpful. This can be done in a dry blood spot, white blood cells, skin fibroblasts, or muscle. Measurement of GAA activity in skin fibroblasts is a gold standard. Cultured fibroblasts are obtained from a skin biopsy and then grown so that they can be used for enzyme testing. This can take 4 to 6 weeks and then can thus significantly delay the diagnosis. With muscle tissue biopsy, it's more invasive, but it does allow the measurement of acid glucosidase activity and glycogen content to be looked at directly and also fairly rapidly. Here, the easiest and the way that most newborn screening programs screen for Pompe is via a dry blood spot. And that's also, the dry blood spot is also what a number of physicians will do, neurologists, geneticists, when they're screening for Pompe disease. So the diagnosis using acid alpha glucosidase, GAA analysis on blood and dry blood spot. How is this done? It's a quantification of GAA using stable isotope dilution tandem mass spectrometry. And there can be some complication with all blood-based methods. There's an interference of this MGA activity at an acidic pH, but this is really has been improved by the addition of acarbose or using another method. And this is just more detail, but it's important that the testing is done right. And this is one piece that can be looked at to determine whether or not the testing was done correctly. What are some of the benefits of the blood-based enzyme assays? You can avoid the invasive skin or the muscle biopsy and the culture time there. The dry blood spot testing is convenient. It's reliable. The results are available fairly rapidly. The false positive is very low, but we do confirm dried blood spot enzyme test with GAA gene sequencing or a second tissue test. This is to give you some background on what the dried blood spot activity looks like. In general, the GAA enzyme activities of about 1% of normals are what are seen in the children with infantile form of Pompe disease. In the late onset forms, the activities can be from 2 to 40% of normal controls, but they can really vary across the tissues, whether they're muscle, comparing muscle to fibroblasts. So skin fibroblast analysis, this is what I mentioned as kind of an older gold standard, but it's still pretty helpful in determining percent residual enzyme activity or phenotype. When we test enzyme on blood, we're really only getting the two sides of not affected or affected. With skin, we can use that enzyme number more specifically. I've often heard patients ask, oh, well, what was your enzyme percentage number? And really, unless it was done on skin, it's not that trustworthy. So here, in the infantile form, a complete deficiency of less than 1% in muscle is seen also in fibroblasts. And then in late onset, it's markedly decreased of about 5 to 30%. But this, again, this method takes about 6 weeks, and that's too long when we're diagnosing children with infantile Pompe. And another method is the molecular diagnosis, and this helps in confirming the diagnosis. In an infantile case, determining CRIM status and the need for immune modulation. If the patient is CRIM negative, we can learn that from the variants that are found. You can determine pseudodeficiency from true affected disease status if you find a pseudodeficiency allele. If the patient had low enzyme and then you found a pseudodeficiency allele without two disease-causing variants, you may be able to say that the patient does not have Pompe. And the variants also help us in differentiating infantile from the late onset forms of the disease. Genetic counseling is important here. It can help identify other family members who are affected or carriers. But there is the challenge of the variant of unknown significance, or VUS, in combination with a pathogenic variant or a pseudodeficiency allele. And this is just where we have a variant where it either hasn't been reported before or there's not a lot of information about it. And we see that in combination with a pathogenic variant. Then you have to look at all the other pieces of lab values, enzyme levels to tell you really, does this look like a true diagnosis of Pompe disease or not? So when we're thinking about molecular diagnosis, what are some things to consider? The GA gene is a highly polymorphic gene, which means that there are a lot of different variants. And a lot of the variants are uncited or not published. When you're looking at molecular variants and you're trying to interpret the variants of unknown significance, thinking about what the enzyme activity was, correlating the clinical features with the variants in the enzyme activity, but also who is doing the molecular testing? Are they very familiar with the gene? Are they aware of the most common variants? What are the polymorphisms? And will their lab tell you if it looks like there's a deletion? And that can be determined by lack of heterozygosity in the molecular testing process. As I mentioned before, determining CRIM status is an important piece, especially when treatment is started, and that can be determined based on molecular diagnosis in a number of cases. In muscle pathology, we do see manifestations of storage material or glycogen on biopsy. You can also do enzyme testing on blood, on muscle. But the problem here is that you really don't want to do a muscle biopsy in an infant that has possible Pompe, especially due to the anesthesia risk. There are some other issues here. It's possible that if the muscle isn't handled correctly, the glycogen might be washed out. In Pompe disease, you may have an area of true damage next to a normal area, and if you biopsy the normal area of muscle, you may not see that glycogen accumulation or the disrupted muscle fibers. So this is a piece of the puzzle, the muscle pathology, but not necessarily the only, it wouldn't be the only method you would use to diagnose Pompe disease. This is one of the pieces I was mentioning, the muscle histopathology. You'll see glycogen-filled vacuoles within the muscle fibers. This can vary from section to section within the muscle, even two muscle sections right next to each other. The vacuoles are more prominent in the infantile and childhood forms and may be absent in adult forms. We do have PAS positive staining, and this is indicative of glycogen accumulation. And glycogen can be found free in the cytoplasm when the lysosomes burst, and you can see that on electron microscopy. So here I've just noted where you can see a more normal muscle fiber right next to one that here you can see the white missing pieces. That's where the glycogen has been washed out. But you can see that if you only biopsied a certain section, you may see normal muscle as opposed to an area that has more damage. And again, that's displayed here in this bottom picture on the right-hand side, where you see more organized muscle fibers and then ones that are disorganized. So there are advantages and disadvantages of muscle biopsy testing. The advantages are that it's direct and rapid. You can assay the tissue fairly quickly. It's useful for both the assay of enzyme and then also the histological evaluation. But there are disadvantages that makes it not the best or the only diagnosis piece. The site of the biopsy and the selection of the muscles can affect the results. The lack of glycogen accumulation doesn't necessarily rule out Pompe. It's invasive. And if the site where the muscle biopsy is done doesn't do enzyme testing, you may have to ship the sample or the processing has to be done correctly. So I think the last piece then involves what are the clinical characteristics and how do we use different clinical tests to give us more information about people with Pompe disease. The clinical symptoms help differentiate infantile versus late onset forms. One blood test that we use is the creatine kinase. It's usually elevated, not uniformly in infantile, usually in late onset, but not always. It's not specific, but does help point to muscle as a source of hypotonia, especially in children that are being diagnosed clinically. Liver enzymes, there can be abnormal liver enzymes, but it's important to realize that these liver enzymes also have a muscle component. So if a patient has abnormal liver enzymes, it may be that the muscle damage is contributing to these. And then a more specific measure for Pompe disease, urine hex 4 or gluc4 is a functional measure of GAA deficiency, and it's elevated uniformly in infantile onset Pompe disease. Some of the clinical tests, echocardiogram can show the hypertrophic cardiomyopathy and is very helpful in distinguishing infantile onset from later onset forms of Pompe disease. And this is often one of the first things that is done when a patient is diagnosed with Pompe disease via newborn screening. They bring the child and the family in and they do an echo. If the echo is fairly normal, then I think that's when they start to look at the family and say, you know, this could be a late onset form. If there's hypertrophic cardiomyopathy, then it's more of a sign that this is infantile form. The EKG, which tells us the rhythm. Chest X-ray can often show the cardiomegaly or the instance of a large heart indicating the hypertrophic cardiomyopathy. Pulmonary function testing, especially in late onset Pompe, we look at the decreased forced vital capacity and the reduced maximal inspiratory and expiratory pressures, MIP and MEP. And then this also tells us that if we do it in the supine position and the FVC further decreases, that there can be some diaphragm involvement. And then the EMG, there is a characteristic pattern, myopathic pattern, including the paraspinal muscles in patients with Pompe disease. So again here, a nice flow chart showing Pompe diagnostic algorithm with DNA sequencing as part of the newborn screening laboratory protocol. And a number of states now do include the molecular testing or the DNA sequencing as part of their screening process. Once they've done the dried blood spot, they follow up with the GA variant testing, and then that information is what's provided to the physicians. This tells us a recommended treatment algorithm for patients with classic infantile Pompe disease, with determining the CRIM status being a very important first step, because then that determines how often you evaluate, whether you start immune modulation, although we are at Duke and other places introducing immune modulation even for CRIM positive patients at this point. So to quickly show the immune tolerance induction regimen, or the process that we use for CRIM negative people or children who have Pompe disease and who are naive to ERT. First, you determine the diagnosis of the CRIM negative status, and then at the time of the first infusion, the patients receive rituximab, methotrexate, and IVIG. And this is repeated for several times during the first 5 weeks of treatment. And then at the 6th week, the treatment process has been, with the immune tolerance has complete. And then at that point, you can decide with the physician whether or not ERT should continue alone, or if more ITI is needed. Here we can see that the overall survival of CRIM negative patients by newborn screening really has increased with the addition of ITI. The orange line here on the Kaplan-Meier survival curve shows that all patients who were diagnosed with Pompe disease who were CRIM negative, who received ITI with ERT, were still alive at this point of about 50 months. Whereas children who were diagnosed clinically, being the green line with some decrease in survival, and then children who were diagnosed clinically without ITI were all deceased by about 50 months. So it's clear that the patients who do the best with the treatment are those that are diagnosed via newborn screening and receive immune tolerance induction. So I talked a little bit about the IVS1 variant, or the more common variant in people diagnosed with late onset Pompe. And one of the questions we asked is, what kind of early presentation are we seeing in the clinical setting? And this was a chart review that we did as we were preparing to look at also the newborn screening patients. But in this study, we looked at a diagnosis of late onset Pompe disease with clearly documented clinical symptom onset within the first 2 years of life. And these were all children who had a clinical diagnosis of Pompe rather than a diagnosis via newborn screening. And out of the 83 patients that were available to study with late onset Pompe, 4 of those fulfilled these criteria, and we were able to look at further. Here you can see some of the characteristics of the 4 patients, and then their age of symptom onset. So as I said before, this IVS glycite is generally associated with less symptoms, a milder course, but you can see here that all of these patients that had this variant that were diagnosed less than 2 years old had some symptoms within the first few days to few months of life. And then you can see that they also all started on enzyme replacement therapy by about 2 months, maybe a little bit over that, with their residual manifestations despite ERT being muscle weakness, some pulmonary, gastrointestinal, genitourinary issues. Here's one of the patients where he's 3 years, 4 months old and had been on ERT for 20 months. And you can see the classic posture here, the anterior pelvic tilt with excessive hip flexion, scapular winging, a lateral trunk lean during the stance phase of gait. And then here at 5 years, 4 months, his enzyme dose was increased. It's actually doubled, but he continues to have the lateral and posterior trunk lean during the stance phase of gait. You can see the head lag here when he's 3 years, 4 months, and he's pulled to set, even when he's given this extra support in his trunk. Although he continues to be fully ambulatory independent here. And then at 8 years old, again, attempting to lift the head to do a sit-up, but still can't lift his head. Now I'll switch gears a little bit and talk a little bit about the genetics of Pompe disease. And this ties back to the molecular testing that I mentioned, but we'll go in a little bit more depth here. So a reminder for everyone, when we're talking about chromosomes and genes and DNA, we have the 23 sets of chromosomes, so we have 46 chromosomes, and on each chromosome, DNA is wound tightly, and each section of DNA is considered a gene. So you can see here, this is called a karyotype, showing the 46 pairs of chromosomes, with the 46 chromosomes, the 23 pairs, with the first 22 pairs being the autosomes, and then the 23rd pair being the sex chromosomes, a Y, an X and a Y here being determining male. So the basic genetics, when we look here, if we, on each copy of the gene for GAA, there's 2 normal copies of the gene, then we would have an unaffected non-carrier. But if we look at the 2 chromosomes that are responsible for where the gene for GAA is located, and we have 1 normal copy of the gene and 1 copy of the gene that has a variant, whether it's mild or severe, this would be a person who is a carrier, an unaffected carrier of Pompe. So if you would think about this as the parent or a sibling of someone who has Pompe. If we have 2 variants, 1 on each copy of the chromosome in each gene, this is what causes infantile Pompe or late onset Pompe. Pompe is inherited in a recessive manner, meaning that each person has 2 variants within the gene that reduce the enzyme activity and therefore cause the disease. The GAA gene is located on chromosome 17. There's more than 900 variants or changes that have been described in the gene. And variants really can affect either the production, so the quantity of the enzyme, or the function, the quality. This is a little bit busy, but what I just wanted to show is that there is a database available online where the different variants are listed, and it tells you what the DNA nomenclature is, the predicted severity, if has been a reported phenotype or picture, and then the CRIM status. And the reference for that is here at the bottom. So when we're talking about Pompe disease, the demographics and the common pathogenic variants, there are some common variants depending on the background. And in infantile Pompe, there's a variant here that's seen in about 9% of US cases and 34% of Dutch cases, and it's thought to be more severe. There's an exon 18 deletion here seen in infantile onset cases and accounts for about 25% of Dutch and Canadian cases, but only about 5% of US cases. There's a known pathogenic variant here for people who have an African American background, people with a Chinese Taiwanese background, a more common variant. And then, as I had mentioned before, people with a Caucasian background who have late onset, about 40 to 80% have this pathogenic IVS splice site. Typically compound heterozygotes, which mean they have this in combination with another gene change. And then I did mention pseudodeficiency a little bit. This is a genetic finding that we see sometimes when we're doing newborn screening. It's more common in Asian populations. Here's the way that we label it or name it based on the cDNA naming system. And it really only decreases the enzyme in the test tube, in vitro. In vivo, within a person, it doesn't affect enzyme and it does not cause disease. but it can be something that causes a low enzyme during newborn screening testing. And then once the molecular testing is done, it's determined that the patient has a pseudodeficiency allele. And then in that case, we know that they're not at risk for Pompe, as long as they don't also have two pathogenic or disease-causing variants. You can predict phenotype somewhat for infantile versus late onset. When we're thinking about the genotype, which is the genetic makeup, and the phenotype, which is the clinical picture, generally the phenotypic presentation for infantile onset is similar among affected family members. So if someone has a child born with infantile Pompe and a sibling then is born and has a similar genetic, has the same genetic makeup, then we would expect that sibling to present similarly to the original proband or the first child born. This is not always the case in late onset Pompe. There can be a variability of age of onset for family members with the same variant. So we've seen this in older people with Pompe, where maybe one sibling presents at age 40. They have an older sibling who's 50 or 60, and they say, well, I'm older, there's no way that I have this. But then it does turn out that that older sibling might also have late onset Pompe. Carrier detection is another piece of genetic testing or genetic counseling. And it really is important to identify additional family members who may be affected or may be carriers. And this is especially important to test siblings of an affected individual. It can be completed through GAA variant analysis when the variants are known. But I'll touch on here that multiple generations could be affected in one family and what that means for testing family members. So careful consideration of family history or symptoms may warrant diagnostic evaluation for family members instead of this targeted familial variant testing. So instead of testing only the two variants that we know are in the family, we might suggest doing enzyme testing on someone who is trying to determine whether or not they have Pompe based on a family member's diagnosis. And then in that case, we may do full gene sequencing. And I'll show you a little more about that. So here, this is a literature review from this paper here that shows the cases, a few cases of multi-generational Pompe disease, where a child and an adult parent, or a child and maybe a grandparent within a same family, were diagnosed with Pompe. And I'll go through a couple cases here. P1 and P2 are an adult Civ pair of Caucasian descent, and P1 was diagnosed with late onset Pompe at 40 years old after presenting with a decade of leg weakness, falls, increased CK, had a muscle biopsy that showed that they have Pompe. And then patient 2 was diagnosed with LOPD Pompe 11 years after, at about age 50, based on the positive family history and some weakness in their legs and muscle strength. Then as we move on, you can see here, P3 is a first cousin twice removed of P1 and P2, and it was initially evaluated at age 2 months for difficulty latching with nursing, hypotonia, and a weak cry. And then at 4 months, P3 developed pneumonia, which then was the cause of death. P4 was a sibling of P3, and because of P3's diagnosis, P4 was diagnosed prenatally and started on enzyme within the first couple days of life. So you can see here that through this family, we have multiple generations affected with Pompe, with 2 different variants of Pompe and different variants within the family. Here, the family proband P1 was of Caucasian descent and was initially evaluated at age 3 months. And according to the mother, there was a heart murmur when the patient was being evaluated for an upper respiratory infection. An echocardiogram showed cardiomegaly and then a diagnosis of infantile Pompe. P2 is the mother of P1 and was diagnosed with late onset Pompe at the age of 39 years, 11 years after her daughter's diagnosis. And her clinical presentation was characterized by several years of weakening muscles. So again, the patient here did not have molecular analysis, but we know that the mom did, but she carried the late onset variant and a more severe variant, which we then assume is one of the variants that the child carried, with another variant inherited from the father. And then a final case here, P1 is the family proband who was initially evaluated at 3 months for tachycardia. And in this hospital, the protocol was also to test children with tachycardia and low tone for Pompe. So this child was diagnosed with late onset or infantile Pompe. P2, the mother was found to have minimally symptomatic late onset Pompe. And once she was tested, as a result of just carrier testing for her child with infantile Pompe, it was found that she had late onset Pompe. So due to that, this mother had 2 variants that she could pass along to her children. So she passed along one of the infantile variants here, and then she passed along her late onset variant to the other 2 children, whereas the dad passed along the infantile variant to all 3. So in this family, we have the proband who was diagnosed with infantile Pompe, and then 3 other people with late onset Pompe. And then here, there's just some more characteristics of each of the families and the individual family members. So why is this important? Well, testing of close family members is important for disease status. And when no one in the family has the disease, often the order of diagnostic tests is enzyme activity and then full gene sequencing. But when someone in the family has the disease, sometimes that testing will look like only looking for the specific familial variants, and it's less expensive than the full gene sequencing. But what we suggest, because we know that there is this higher carrier rate possibly, and that more than 2 variants can be found in a family, we would suggest that no matter what, you do enzyme activity, and then that can help you determine whether or not targeted genetic testing or full gene sequencing, whether the patient falls in the normal range, normal/carrier range, or the affected range. So morbidity and mortality can be reduced by early diagnosis and treatment with ERT. And it is imperative to offer siblings of infected individuals testing of GA activity or molecular genetic testing. Ensuring that laboratories are testing familial variants using correct testing assumptions and testing based on symptoms. Genetic testing and genetic counseling is important because it can help confirm the diagnosis, predict the phenotype, aid in interpretation of genetic testing results, help determine testing strategies for multiple generations in one family, coordinate treatment and management. And then just to test or to touch a little bit on prenatal testing. Prenatal testing for Pompe disease is available. There's a number of different ways this can be done early in the pregnancy or a little bit later. And here I just provide a little information on that. So a summary of the key points. There are many different variants that can cause Pompe disease. The disease prevalence and carrier frequency is far higher than previously thought. Greater than 2 variants may be present in an extended family, and this has specific implications for testing family members. So here, I was able to touch on a little bit of all of these topics. I hope that you were able to take away some knowledge and maybe some things that you didn't know in the past. Here's my contact information. Please feel free to reach out if you have any questions.